I'm very grateful to the organizers for CAS for inviting me for this very important plenary lecture. I bring greetings from the Institute of Liver and Biliary Sciences. I have nothing to disclose. I would try and cover in acute liver failure and an acute on chronic liver failure the bridging therapies. These include Mars, Prometheus, CRRT, and high volume or standard volume plasma exchange, and some other new protocols. Why we need it? Out of 100, maybe one gets a transplant. So we need to give time for making the liver available or the liver to regenerate by itself. Cerebral edema is one of the commonest complications, 70% of the ALF patients. This is because of high ammonia. There is a huge systemic inflammatory response. There is a problem of clearance of dams, cytokines, and endotoxins. And in a week's time, there would be sepsis developing and hemodynamic compromises, all in first 1 week. The ammonia levels, if they are more than 126, are likely to make a patient non-survivor. And mortality, renal problems, ventilatory problems are all when the ammonia levels are above 124. Damage-associated molecular patterns include uric acid, HSPs, nuclei, HMG, GB1. All these are products of the cellular debris. They can also have several of the plasma membrane proteins coming up, mitochondrial debris coming. So when you have all these coming out from a necrotic cell, they will be taken up and an inflammasome is formed. In addition, you have extracellular matrix outside the liver cells, which also gets into the HMB, into the damage-associated molecular patterns. All these, when they circulate, can become really antigens and provocate the immunity of the cell. Liver injury can also stimulate kidney and can produce a problem for the renal functions. Let's look at when the liver failure occurs, ALF, there is increased ammonia, cerebral perfusion increases. This will cause cerebral edema and aquaporin 4. Also, inflammation will occur. The hyponatremia, the problems with the acute kidney injury, there is an increased blood-brain barrier permeability. All these infections, inflammations, and cerebral edema add to problems, and that is added upon by kidney injury. We have the fractional plasma separation and the Mars, these two methods. In the Prometheus system, the membrane is a bit wide and it includes both the albumin bound and unbound. Both the kinds of proteins are taken away in the system. It's a large bore system, while the membrane Mars is smaller. On this dialysis system, it will only take up the toxins which are albumin bound and it will be taken away. The whole molecule will not, and the medium molecules will not be separated out by this. Mars was tried in acute liver failure. In this randomized controlled trial published a few years ago in the 16 French centers called Fulmar study, the difference between the Mars and the conventional therapies was not very significant. It did not improve survival. We also have done Prometheus, the FPSA system, in patients with acute liver failure. Of the 7 patients, post-dialysis, bilirubin came down, the creatinine values slightly improved, lactates improved, ammonia improved, and INR also improved. However, it did not add to improvement in survival. People have used continuous renal replacement therapy, and this has been shown to in the US acute liver failure study group has been shown to be beneficial compared to renal replacement therapy alone. So a CRRT has been shown as in this model to have reduced the mortality, and this has been compared over a period of time. High volume plasma exchange in this study by Larson et al. Compared to standard medical therapy was shown to have an improvement in the survival. And when you compare this, when patients had no high volume plasma exchange or liver transplant, the worst more survival, as compared to that when the patients had high volume plasma exchange but no transplant, even then the survival improved by 10 to 15%. Of course, having high volume plasma exchange and liver transplant as a bridge, this was amongst the best therapies, but it can occur. This is 1.5 times the plasma volume which is exchanged. We undertook a study in 126 patients, very recently published. 20 received standard therapy plus plasma exchange, and another just standard medical therapy. A large number of patients were not eligible. What is interesting is to see that plasma exchange reduced the IL-2 levels, this is on day 5, IL-1 beta levels, IL-6 levels. Also, it shows that the anti-inflammatory levels, IL-1RA, significantly increased. What we did not like was that plasma exchange also reduced the GCSF or PDGF or other growth factors which are useful for liver regeneration. So this remains a limitation. Other than that, plasma exchange was quite helpful. The endotoxin levels on plasma exchange significantly reduced by day 5. Plasma exchange also removed the damage associated molecular patterns. You can see HSP, this is post therapy. You can see that HSP 70, 60, HMGB1, all of them in this group where there is a plasma exchange plus standard medical therapy, in all of them there was an improvement. Plasma exchange also reduced von Willebrand factor, which is a marker of endothelial damage, and it restored the cleavage protein of von Willebrand factor ADAMTS13. So when this was given, there was a reduction in the von Willebrand factor, as you can see, significantly. And an important part of the study is, can you differentiate whether this patient will respond to plasma exchange or not? Now here is a non-responder to plasma exchange, the blue levels. The red is also a non-responder. So this is the patient pre and post plasma exchange who is a non-responder compared to the one who is a responder. What do you see in this? The oxygen consumption rate in the monocytes has increased tremendously in this patient after plasma exchange. So this only shows that plasma exchange can make your immune cells again viable. They can go into OXPHOS and what is mitochondrial respiration. This is the summary slide. In a patient with acute liver failure, there is a huge hepatocyte death, which leads to activation of Kupffer cells, inflammation, DEMS are released inside, and also PEMS, because of poor Kupffer cell function, are also released inside. This leads to cerebral edema, kidney injury, cardiac dysfunction. And the endothelium is damaged, which leads to von Willebrand factor and reduced ADAMTS. What therapeutic plasma exchange does in this improves the monocyte functions and restores the organ functions and decreases DEMS. By using this, we were able to show that the standard volume, not 1.5 high volume, even the standard volume which avoids the overload was superior to standard medical therapy in achieving 21-day transplant-free survival. So the bridging therapies in acute liver failure to me today appears best as plasma exchange, reducing ammonia, inflammatory cytokines and DEMS, ameliorates SIRS, cerebral edema, and improves hemodynamics. Liver dialysis, we have limited data. CRRT does improve ammonia, lactate clearance, cerebral edema. These could be bridged towards spontaneous regeneration or transplantation. However, I must say none is an alternative to liver transplant. Acute on chronic liver failure makes 30% of admissions today to the hospital. There are several definitions, and I would like to use this platform to say ALF, I told you, normal liver. A decompensated cirrhosis for 4 years, many years, when the pie gets an acute insult, there is further worsening of the decompensated cirrhosis like sepsis, bleed, AKI, HE, sepsis. These all are the natural course of the end stage liver disease. What we are talking is a patient with F3, F4 fibrosis who gets an acute insult, or a known compensated cirrhosis who gets an acute insult. Now, this insult can be a variceal bleed, HE, ascites, HRS, sepsis, or any combination. Or it can lead to a hepatic insult, a liver failure, and that liver failure, either in F3, F4, or in a patient with compensated cirrhosis, is called as acute on chronic liver failure. So liver cell death, the jaundice, leads to development of ascites and acute portal hypertension syndrome. This is a homogeneous group. Otherwise, there are almost 27 definitions when you use the Western definitions. And if you use the North American Consortium for ASLD, there are only ICU end-stage liver disease patients. So let us stick to what we call as ACLF, jaundice, coagulopathy, and ascites. When you use the Western definition of Easel-Cliff, then the jaundice, with or without, you have to have an extrahepatic organ failure, like kidney, brain, 2 organ failure. While in the APASL, liver failure precedes, and this is followed by other organ failure. So this is true to the name, and it also detects the liver failure about 6 days, ACLF 6 to 10 days earlier. There is a score for the first time, APASL ACLF Research Consortium score, which uses 4 variables from the liver and 1 from the kidney. And this patient, which I have not shown, the ARC score is 13. Kidney is bad, lactate is high, INR is high, and bilirubin is high, even though patient is not in HE. So there is a grade of grade 3 liver failure. Like you have KCH, you have very simple ARC score. If the ARC score is less than 10, then 1 unit increase, let's say from 8 to 9 or 7 to 8, by day 7, mortality increases by 5%. However, if you have an ARC score of 10 or 11, then there is an increase in mortality by 20% with 1 unit increase. This is the most dynamic, most useful score and far superior than Cliff or Apache scores. What happens in ACLF? There is a liver injury in a chronic liver disease, alcohol or virus or drugs, cell death. All the sensors, the immune sensors are there. The portal blood brings the endotoxins and bacterial translocation. This leads to development of several cytokines. Hyperkinetic circulation develops due to these cytokine release, and this cycle continues. So the mediators, the sensors lead to organ failure. Albumin in ACLF is an area of huge interest. The synthesis decreases. One albumin molecule normally binds to 1 bilirubin, but in ACLF, 3 bilirubin molecules bind to 1 albumin. So now albumin molecule cannot bind drugs, cannot bind toxins. It becomes useless. This albumin is dysfunctional, endothelial injury occurs, nitrosoalbumin nitric oxide added will lead to vasodilation. It changes your innate cells, adaptive immunity goes down, and there is also variations like increased forms of non-mercapt albumin. These are very toxic albumins, HNA1, HNA2, and therefore addition of albumin in ACLF patients is risky. Maybe we should dialyze, remove the toxic bad albumin. So this is the rationale for removal and not merely replacing hyperoxidized albumin. There is also a release of iron. We have shown that multi-organ failure in acute on chronic liver failure is due to dysregulated iron homeostasis. As I showed you earlier, both Prometheus and Mars systems have been used for removal of these toxins. This early study showed in 145 patients that there is a limited advantage. However, in the Helio study, when you use patients with high MELD score, then this was superior to standard medical therapy. Plasma exchange has been used in ACLF also. This helps in detoxification, biosynthesis, and homeostasis. And detoxification, we remove toxins. Heme adsorption, another thing which I will show you, has beneficial effect. It removes bilirubin, removes bile acids. We also, by removing ACLF, by removing the toxins, we can allow regeneration of the liver. However, we have to add maybe GCSF. And homeostasis has to be achieved. Fecal microbial transplant and GCSF can help in this. In this study, we compared the albumin dialysis with plasma exchange, which had a far superior survival benefit as compared to the albumin dialysis. In this study published last year at the AASLD, a trial of hemoperfusion versus plasma exchange. What we achieved was by giving the plasma exchange versus the heme adsorption, we were able to decrease bilirubin, we were able to decrease bile acids much more than plasma exchange, and therefore this was a benefit to us as far as organ failure was concerned. On day 7, compared to standard therapy, you can see heme adsorption had less organ failure on day 7 as well as on day 28. Immune paresis is another problem, and this is because, as I showed you, cellular oxygen goes down. Neutrophils, monocytes, dendritic cells, T cells, all of them are impaired, and therefore they develop sepsis. We conducted a survey in globally where 84 transplant centers were asked. They said almost half of them that sepsis is the commonest cause, or two organ failures is the commonest cause of not undertaking liver transplant. In this study, we showed a patient with cirrhosis who gets an ACLF. There is a neutrophil dysfunction. If you give GCSF in them, in carefully selected patient, you can have restoration of neutrophil function. It can prevent sepsis. It improves dendritic cell function, and all other complications, organ failures can be reduced. GCSF also mobilizes bone marrow stem cells, CD34 cells. You can see that compared to pre-therapy, post-therapy in transjugular biopsies, almost twofold increase in the CD34 cells in the liver, and this led to an improved survival compared to placebo. This also shows you in another study, which we showed that combining the EPO, the erythropoietin with GCSF can further improve the CD34 and CD133 cell migration from bone marrow to the liver. This led to an improved survival and reduced sepsis compared to placebo. GCSF and darbepoetin reduced, this was given for 2 months, reduced the development of sepsis. FMT, in a pilot study we showed in severe alcoholic hepatitis, compared to a control group, FMT in 8 patients, the survival benefit was seen. In another trial, which was presented as a plenary at the AASL and achieved the Best Paper Award, was combining FMT plus tenofovir with tenofovir alone, and FMT improved survival. So tenofovir decreases the HBV virus, while FMT actually immune modulates through the gut mucosa associated invariant T cells. These are the current ILBS protocols for ACLF. Hepatitis B, tenofovir. For alcohol, steroids. We try to suppress inflammation. Steroid, GCSF, FMT. We prevent sepsis, ameliorate liver injury, and we give as bridging therapy plasmapheresis, liver dialysis, that this patient can finally get a definitive therapy. This is the current management protocol 2021. Patient comes, see if there is any sepsis, prevent it, optimize the organs. If the MELD is above 30 or ARC score is above 10, this patient needs transplant. No discussion, first week transplant. If the patient has an improvement while you're working up for transplant, by day 4 to 7, you can actually do medical therapy. However, if the ARC score is increasing or MELD is increasing, this patient will need an emergency transplant. On the other hand, if patient comes using Cliff criteria or Western criteria with 2 extra organ failures, this patient will probably need a bridge therapy and to stabilize him and then take for emergency transplant. If he is not improving, supportive care. On the other hand, if he has multi-organ failure, directly supportive care. We all request you that you can submit to Hepatology International with a good impact factor and also join the national and international collaborations on ARC throughout Asia. Thank you one more time for inviting me for this very prestigious talk. Thank you, CAST Organizing Committee.